So my name is Ben Enfield, one of the second-year residents here, and wanted to talk today about some select studies on selective laser trabeculoplasty and how it could be potentially used more often than what we do. No disclosures here, and just wanted to start with a brief case that I saw recently with a 66-year-old African-American gentleman. He had a newly diagnosed optic neuropathy of the right eye. Sent to neuro-ophthalmology clinic to make sure that there was kind of nothing else going on with it and get a second opinion on what the cause of it was. Had a family history, including his grandmother and father, of going blind from glaucoma. And he saw his ophthalmologist for the first time June 12, 2020, where his pressure was elevated at 35 in the right eye, 30 in the left eye, significant cupping in the right eye, and some cupping in the left eye, but not as much. It was asymmetric. And we started on latanoprost and timolol on both eyes. And here at our exam, we saw him recently just a few days ago, he was count fingers at face in the right eye and 20/20 in the left eye. His pressures were much better at 12 and 11. He had a positive RAPD in the right eye and normal motility. And here we got some fundus photos, and you can see in the right eye that he has significant cupping of that eye, very thin rim. And in the left eye, there was cupping as well, but not nearly as pronounced, and still had a healthy rim in that eye. For our visual field testing, we can see that the left eye has, some early arcuate nasal changes, but otherwise fairly good. And then the right eye was completely blacked out due to his poor visual acuity. And then we got OCT RNFL, which showed superior and inferior thinning in the right eye with increased cup to disc ratio, all kind of going along with the diagnosis of glaucoma. And the reason that I bring this patient up is because, he had a history of cancer, they had a brain MRI, it was normal, we diagnosed him and reassured the ophthalmologist that it was in fact glaucoma. But he brought up to me in our discussion, he's had to take these drops. He was commenting about how difficult it was for him. He had never had to take medications in his life. And I wanted to know if there was other options besides drops or surgery. So we kind of had a little discussion for him to follow up with his primary ophthalmologist and to consider laser treatment for reducing pressure in the eyes as well as an adjunct. And so in doing this, I wanted to research a little bit about SLT and some new studies that have come out over the last few years to kind of demonstrate its efficacy. So one big one that came out about a year ago was this selective laser trabeculoplasty versus eye drops for first-line treatment of ocular hypertension and glaucoma. And it was a large multi-center randomized controlled trial that was very well done to be able to look at exactly how well SLT works in comparison to drops, the side effects, and looked at it over a 36-month period. So for this case, they looked at newly diagnosed untreated open-angle glaucoma or ocular hypertension patients in one or both eyes at multi-center areas and consecutively signed them up for this study over a period of time. They had to have visual field loss with a mean deviation on visual field testing not worse than minus 12 decibels in the better eye or minus 15 in the worse eye, and corresponding damage to the optic nerve. So essentially, they did not let them go into the study if they had very advanced glaucoma. And they had to have a visual acuity of 21/20 or better in the eyes to be treated, and no previous history of intraocular surgery, except for cataract surgery within the last year. That was uncomplicated. One of the things that they did was that they set specific set endpoints using software and an algorithm to assess disease severity, pre-treatment intraocular pressures based on their initial intraocular pressures, and objective patient-specific pressure targets, treatment intensities, and monitoring intervals. And that was adjusted based on the intraocular pressure, disease stability, and adverse reactions. And so they had this all set in an algorithm ahead of time, so that way the practitioners wouldn't try to change their course of treatment based on if they had SLT or pressure drops first. And they used many of the common criteria for assessing glaucoma severity, as well as other goals in treatment of the intraocular pressure and the goal pressure. They randomly assigned patients to either eye drops first or SLT first, followed by topical medications. And treatment was escalated in this study when there was either strong evidence of deterioration, irrespective of the IOP, an IOP above the target by more than 4, or an IOP above the target by less than 4, and some less strong evidence of progression. Target IOP was reduced by 20% if deterioration was identified, despite the measured IOP being at or below target. So this is just some kind of background information to tell you, what they did during the study and how they escalated treatment in both groups. And so what they did was they did SLT delivered 360 degrees with 100 non-overlapping shots, 25 per quadrant, with 2 specific physicians that were applying these treatments. And one retreatment with SLT was allowed if there had been a reduction in IOP after the initial treatment. Otherwise, they escalated to medical therapy and drops. For their algorithm, the first line use was prostaglandins. The second line was beta blockers. And then the third or fourth line was either topical carbonic anhydrase inhibitors or alpha agonists. So in this study, they had 718 patients in 1,235 eyes that were randomly assigned. 356 patients and 613 eyes were in the SLT group, and 362 patients with 622 eyes were in the eye drop group. 555 patients had open-angle glaucoma diagnosis in at least one eye, and 163 had ocular hypertension. And if we look at their baseline ocular characteristics here at this table, we can see that the majority of them were either ocular hypertension or mild open-angle glaucoma, and less often was it moderate or severe, which is a limitation in the study, that they generally looked at patients that were newly diagnosed, and most of those patients had ocular hypertension or mild open-angle glaucoma. So now we look at the number of drops of medication per eye at target eye at 36 months, and some of the results of this study. In the drop group, there were 16 eyes that were on no medication at target IOP, which was just 3%, versus the SLT group, there was 78.2% of the group that were on no medications at target IOP at 36 months, which is pretty significant. And then we can kind of see, how many of these SLT and drops, most of the patients that were on drops had to be on 1 drop, some of them had to be on more, and that's the same with the SLT group. And the amount of eyes not at target at 36 months was 7% in the drops group and 5% in the SLT group. And we can see that the eyes at the target IOP, like we mentioned, in the drops group was 93%, SLT group was 95%. So slightly more eyes were at target IOP at 36 months in the SLT group. They both had pretty similar treatment escalations, although there was less in the SLT group and there was less disease progression during the trial. From the amount of people that went from ocular hypertension to open-angle glaucoma, it was roughly the same, and they used an algorithm to find progression analysis prior to the study beginning. In terms of the number of surgeries during the trial, there were less surgeries, specifically glaucoma surgeries for the SLT group compared to the glaucoma, compared to the drop group that needed to have some trabeculectomy surgeries in order to reduce the pressure to a target goal without progression. One of the things that they wanted to look at in this study was specifically looking at cost effectiveness and also quality of life. So they did a number of different quality of life questionnaires. They were hopeful that the quality of life would be high, not hopeful, but I think that they thought that the quality of life would be a little bit higher in the group that had SLT first, because it would require less of a drop burden, and then the cost was lower to the system. But they found in their analysis that there was no significant difference in quality of life questionnaires at the end of 36 months in SLT groups versus the drops group. In 6 eyes of 6 patients, the IOP rose on the day of laser treatment by more than 5, but only 1 eye required treatment, which is pretty significant because they did over 700 SLT procedures, and only in 1 of those patients did they have to intervene with another eye drop to be able to lower the pressure from it. There were slightly more ophthalmic drop-related adverse events in the eye drops group, which would be understandable. Most of them were side effects of increased redness or allergic reactions compared to the SLT group. And they found that SLT as a first-line treatment overall, even when including drop escalation therapy with SLT, cost 458 pounds less than the eye drops group. And this study was done in the UK, so that's why we have that information there. In the eye drop group, 36 patients, which was 5.8%, had disease progression compared with 3.8% of patients in the SLT group. And 74% of those in the SLT group remained drop-free at 3 years, which is pretty amazing. The laser-first approach, and there's kind of in conclusion, they found that the laser-first approach provided better control of intraocular pressure over the course of the 3 years, more visits at target IOP, less intense drop treatment, and they had no glaucoma surgeries that were necessary. And one of the kind of conclusions or discussions points that they had was that this may be because control of IOP after laser relies less on patient adherence and better kind of a diurnal intraocular pressure management over a longer period of time, because there was continuous effect on the trabecular meshwork in contrast to an episodic administration of eye drops that doesn't have a consistent effect on the trabecular meshwork at all times. There was only one patient in SLT group that had a spike of intraocular pressure requiring treatment out of the 776 SLTs. And previously, this rate had been reported to be up to 28 to 30%, which was significantly lower. And so they had a treatment algorithm where 2 weeks after the SLT, they had a pressure check just to make sure that there was no spike. And they ended up changing their practice because they only had that one case that didn't have any long-term side effects of having a pressure higher at that 2-week visit. And so they found that it was unnecessary to do that, which also helped, would help in the future for cost savings of SLT. So we looked at that study, and it's pretty amazing. They had some, obviously, we talked about they had some issues where it's not very applicable to moderate or severe glaucoma, and they looked at SLT first rather than how SLT does in terms of patients that are already on medications. So how well does SLT work if you're already taking 2 or 3 drops? So I looked at another study that was done in 2014, and this study looked at intraocular pressure lowering medications and long-term outcomes of SLT. And this study wanted to determine whether SLT offered similar effect and benefits to patients on no therapy, all the way up to 1, 2, 3 maximal medical therapy, and study the possible effects of medication types on how efficacious it was. These patients had open-angle pseudoexfoliation or pigmentary glaucoma, as well as ocular hypertension, and they all required IOP lowering and were treated with SLT for the first time. They had not had it previously. There were 206 patients initially, but they only had 55 at the end of the study due to either patients needing additional intervention or being lost to follow-up. So that's a relative drawback to this study, is that the amount of patients were definitely less. And there were 20 patients on no therapy, 33 patients on 1 therapy, 61 on 2 drops, and 92 on 3 or more. So we really had a good look at patients that were already on therapy going in to have SLT performed. In this study, they found that groups on none all the way to maximal greater than or equal to 3 medications all showed a fall in IOP after the first time that they had SLT. And they had a response rate of IOP reduction in 44 to 60% of their patients. There were no significant interactions between the number of medications and the post-treatment IOP response over time. And the number of pre-SLT IOP lowering medications did not alter the effectiveness of SLT. And so this is a pretty interesting study to show, because now we know that if it's used as a first-line treatment, it's effective. We also have some evidence that they had SLT response even if they were already on medications, which is great. And then we looked at SLT and what it is, and it utilizes a Q-switched 532 nanometer frequency doubled YAG laser to theoretically target the trabecular meshwork pigmented cells. And to look at it a little bit more in depth, there's a study that came out by looking at the mechanism of action of SLT and predictors of response. And they really wanted to see if ALT, which had been shown previously to increase aqueous outflow facility, if SLT was similar to that. And the question being, SLT delivers only about 1% of the total energy used by ALT. and it doesn't have the thermocoagulative effects like ALT. And so there's been theories that maybe it works in a different mechanism and it doesn't just increase aqueous outflow facility. So they did a prospective study looking at 31 subjects that had either ocular hypertension, glaucoma suspect, or primary open-angle glaucoma. And they used a washout period of topical medications if there was any medications being used for a period of time until they had no longer an effect on their intraocular pressure. They looked at baseline aqueous hemodynamic measurements with a number of different studies. And with the SLT itself, they looked at 80 spots treated over 360 degrees. And then 3 months later, repeated the aqueous hemodynamic measurements to see what the effect was. 11 of these patients had SLT as a first-line treatment. 12 were an alternative to medications. 8 were due to poor compliance, wanting SLT to have a longer effect. And overall, there was pretty equal study subjects that were Caucasian, African American, and one each Hispanic and Asian. And so looking at this, we look at and see kind of what their aqueous hemodynamic parameters at baseline and 3 months after SLT in the treated eye and the contralateral control eye. And really the main things that they found was that the intraocular pressure after 3 months in the treatment eye did have significant reduction that was statistically significant, and the control eye did not have any change in their intraocular pressure, which is to be expected, but there had been some studies kind of alluding to the fact that maybe there could be contralateral effects on the untreated SLT eye previously, and so that's one of the things that they wanted to study, specifically in this study. And they looked at measurements of aqueous flow, outflow facility, and as well as episcleral venous flow. And the only thing that they found significant in their study was that there was increased aqueous outflow facility. Otherwise, and then in the control eye, there was no increase in that. No change in uveoscleral outflow was detected, and in their conclusion, similar to ALT, the IOP lowering effect of SLT appears to be mediated through an increase in outflow facility with no substantial effects on any of the other parameters of aqueous hemodynamics. The contralateral eyes were studied, as we talked about, and it showed that they had no effect on the contralateral eye. And that kind of went to help kind of put past speculations a little bit to rest, not definitively, but it provides more evidence that it doesn't seem to have a contralateral effect on the SLT. There was no change in outflow facility in subjects who did not have a good IOP response to SLT. So patients that weren't responders, they did not have increased outflow facility, even if their IOP didn't change. And the patients with the best response had the highest intraocular pressure at baseline. So just kind of in review, wanted to look at a few studies that I think are exciting for SLT, and it really made me think at least a little bit more about when we see patients for the first time with either ocular hypertension or glaucoma, offering SLT as a first-line treatment is definitely something that is useful, and I think that we could be doing it a little more often, at least in the resident clinic, and these kind of helped show me that the side effects were very well tolerated, and it's a relatively simple procedure. It takes very little time, and given the difficulty with follow-up at places like Grady, that it might be something that we could use to more of an advantage. Obviously, there's limitations in all of these studies, and especially looking at more severe or advanced glaucoma, that's a major limitation that we really didn't see much evidence in terms of this more severe glaucoma, and that would be something that would be more interesting to look at in the future. That's all I have here. These are the references for the studies, and are there any questions?